Good afternoon, everyone. This is Andrew Missel here with Rachel Nyako at New York-Presbyterian PPS. Just doing a quick audio check. Can folks on the line hear us?
Yes.
Awesome. Okay. Very much appreciate that. We're going to go ahead and put everyone else back on mute so that we can reduce as much background noise as possible. So we apologize for that in advance. We're going to be pausing a few locations in the presentation to open it up for questions. We're not going to wait to the end. So if you have questions, please send them through the chat feature in the WebEx bar. And in the meantime, and then during that time, if you have a question, we'll go ahead and unmute lines. But if for some reason we accidentally miss yours, you can usually press *6 or #6 to unmute yourself on the WebEx line. So let's go ahead and jump in. Today's session is going to focus on some of the incremental initial steps outlined in the New York State VBP roadmap document. Really the goal for this is to understand how New York State is viewing DSRIP as preparation for kind of risk-taking and reform beyond the end of the DSRIP grant period. Next, one of the other lessons we'd like to talk about is how the value of CBOs is expected to be reflected in future MCO contracting, and what, sorry about that, just having some background noise. Understanding some of the patient populations reflected in those contracts that the state is looking to emphasize. Just a reminder for folks joining, if you can go ahead and please mute your lines as you join, just like literally mute on your phone, that would be super helpful. Thanks so much. So we do want to link this presentation to the presentation given by our sister PPS, New York-Presbyterian Queens. That was 2 weeks ago. It's VBP 101. That was specifically for CBOs. And it covered a lot of basic terminology, some national trends, and a little bit more detail on the specific VBP arrangement options that are available to future contracts. This slide is just a listing of those sessions. We've grayed out the ones that have happened already. Obviously today, February 28th, we're here to all gather to talk to this second session for CBO providers specifically. And we're going to be rounding out our DSRIP Year 3 trainings in March with 2 trainings based on specifically for primary care providers. You're more than welcome to join those as well, or if you have colleagues at primary care provider organizations or IPAs that you think they would find the information interesting, or you're just curious to hear what that conversation is like, you're more than welcome to join. You don't take attendance or anything like that. And if you miss a presentation, all of the past presentation recordings and materials are saved on our website, and we'll include that in the notes, but it's nyp.org/pps/resources/pps-webinars. And we'll go ahead and send out that link in an attachment after this presentation. Okay, so you've been hearing me ramble on for a few minutes about housekeeping. My name is Andrew Missel, and I'm a manager of DSRIP strategy and project management with the New York PPS. I manage all of our governance committees, and I manage our some of our training deliverables along with my partner, Rachel Nyako. So let's look at just a high level where we are at in VBP today and kind of how we got there. So in 2011, New York State Governor Cuomo created the Medicaid redesign team, or the MRT, and that allowed the state to develop a series of recommendations to lower basically costs and spending.
Good. I'm just getting.
Could folks on the line please mute themselves? Everybody. Yeah, we're going to pause just for a second, and we're going to mute everyone's line. Okay, sorry about that. We are back. Okay, hopefully that's it. Again, sorry for the interruptions. We're still kind of learning the WebEx system here. So as I was saying, kind of the starting point for all of this kicked off in 2011 with the launch of the MRT at the New York State level, and the goal of this was sort of an innovation lab to really generate ways to reform state Medicaid payments and to find ways to reduce spending and utilization for that population. In 2014, as part of that MRT effort, New York State obtained an 1115 waiver from the federal CMS, which allowed us to convert to kind of continue the payment reform journey, and it allowed New York State to reinvest Medicaid dollars and savings back into the redesign of the New York system, New York Health Medicaid delivery system, which is a really roundabout way of saying it helped create the DSRIP program. In 2015, then as part of the DSRIP program, we began to look at how the DSRIP program would eventually evolve into value-based payment and support this goal of putting 80% of value-based payments, 80% of payments in Medicaid tied to value-based payments by the end of the DSRIP program. And really in 2016, we started seeing the DSRIP PPSs kicking off and making infrastructural changes to the delivery system itself. And by the end of this 2020-2021 period is kind of that goal of when we would hope to get 80% of payments tied to value-based contracts. So let's get a little bit more gritty. That's kind of the really high level. Let's take it down one more level, and let's talk about VBP risk levels. Apologies for anyone on the line for whom this might be a review of the VBP 101 class, but the New York State VBP roadmap is defining 3 different levels of risk that VBP contracting between providers and payers can take on. And the levels are structured so that as providers move up a level, they assume greater financial responsibilities for spending that exceeds a benchmark that's set in the contract. And kind of on the flip side of that, they may also then be eligible for to recoup an additional proportion of those savings that might be created as a result of that quality or reform work within the contract. So we'll walk through these 4 different risk levels. The first level is kind of what we call risk level 0. This is still really living in an enhanced fee-for-service world. Providers are eligible for a quality bonus. You know, a lot of the efforts can go, a lot of the payments can be used to support care coordination work. So beyond that, this is not a level of risk that the state considers to qualify for that 80% goal. All right, we're pausing to mute again on the line.
For those on the line that haven't muted themselves, please just go ahead and mute yourselves on your end so we can cancel out any of the background noise and anything you may be doing.
Okay. Thank you, everyone. Sorry, again, a million apologies for the interruption. So, as we were saying, level 0 is kind of the starting point for everybody. If you're living in fee-for-service and haven't really done any VBP contracting of any kind up until this point, it's just, it's basically the status quo for Medicaid care delivery at this point. And because of that, anyone existing kind of in this VBP level 0, those contracts don't count toward that 80% by 2020 goal. those start to count in levels 1 through 3. So level 1, and kind of the way to think about this, like you might have seen some VBP presentations or like an MSSP ACO presentation that uses like a standard normal curve with sort of, they talk about two-tailed risk or upside and downside risk. That's kind of what the differences get to be in levels 1, 2, and 3. So for level 1, this is really only bonus payments. So we'll call that upside only risk. You're still receiving fee-for-service payments, but there's a built-in incentive to reduce costs and quality and utilization. There's no downside if costs sort of exceed benchmarks. There's only bonuses if cost or quality targets are met. In level 2, there's both upside and downside risk, meaning you're at risk for costs or quality targets that aren't met or fall below a certain level, but you are eligible for bonuses if you improve during the measurement period, and payment is retrospective, sort of measured at the end of the year. The VBP level 3 is what we call prospective payments, and this is really taking you completely out of a fee-for-service environment where you're getting a bolus of dollars either at the beginning of the year or on a per member per month basis, and really the provider is coordinating and managing all aspects of care. It's usually considered to be where the largest margins are possible, but it's also the areas of largest risk. So we'll pause there for questions. The best way to do this, just for the sake of interruptions, might be to ask folks to submit questions via chat, or to take yourself off of mute by pressing *6 or #6 and posing your questions. Okay, any questions at all about contracting levels, anything like that? I understand it's kind of a review from where we're at. Okay. So let's talk now. That was kind of a really high-level view. Let's peel away one layer of the onion and let's get a little bit more specific about the VBP document itself. So there are kind of 3 main pieces. And if you look at the VBP roadmap document that states provided, it's rather lengthy. So our presentation today is really focusing on maybe the first 15, 20 pages of that, just to kind of keep it a little bit more simple and to sort of really focus the conversation. So there are 3 main aspects that we wanted to pull out here. One is that the roadmap is really puts a lot of emphasis, and I would say incentivizes Medicaid, managed care organizations, but in this case Medicaid managed care organizations or MCOs. It really incentivizes them to work with you to identify social determinants of health that are relevant for the populations that they are covering, and supporting your implementation of those interventions. If you kind of reverse that thinking, the roadmap speaks directly to CBOs and asks you to identify what your key value proposition is and what your key measures of success have been, and to work with you to articulate those to provider organizations and MCOs so they can bring you into the fold into these contracts and allow you to really wrap yourselves around that population. The second thing is that it specifically encourages you to measure your impact. This is something that within our PPS specifically, organizations like God's Love We Deliver have done a tremendously good job of, working with universities to establish peer review level work and studies of their interventions to really specifically articulate their value. Those are great examples of doing work now that will allow you to make a stronger pitch to provider organizations in the future. And then the third aspect that the roadmap document makes really clear is that it actually specifically requires new plans at VBP risk levels 2 and 3 to include Tier 1 CBOs as integral contracted partners. Those contracts at levels 2 and 3 won't be approved unless there's a CBO on board as well. And the thinking behind that is the state realistically wants to acknowledge that we can't move population health forward if we are only focusing on primary care delivery and ED utilization. We have to look more holistically. So to that point, and this is a good self-reflection. I was talking with a CBO the other day. The concept of CBO tiers is relatively new, and it's not a self-reflection that everyone has had a chance to do yet. So we wanted to take a moment here, and so everybody, put on your home organization thinking cap, and take a look at these different tiers and see which one of these rings most true to you. And really, the state's goal is to really help everybody be classified as one of these 3 tiers. So Tier 1 CBO is a nonprofit, non-Medicaid billing organization, and when they say non-billing, they literally mean not a single dollar's worth of Medicaid billing. A lot of these types of organizations are going to be meal and food supportive services, social services, housing, and religious organizations. Tier 2, what differentiates Tier 2 from Tier 1 is the presence of some Medicaid billing, but Medicaid billing for non-clinical services. So this could be transportation and care coordination as one of the big examples that the state provides. And Tier 3 includes Medicaid billing. There might be some billing then for clinical or clinical support services, but those services have to be licensed and officially recognized by the state. And we wanted to, how do we describe this? It's important to note that Tier 1 CBOs aren't required to enter into risk-sharing agreements. How do I put this? Providers participating in VBP contracts at risk levels 2 and 3 need to work with a Tier 1 CBO, but not all Tier 1 CBOs are being asked to enter into risk-based contracts. It's sort of we wanted to draw a big distinction to that requirement. And so to say it another way, if you're an MCO or a provider organization entering into a contract, they are required to work with you, but you as a CBO are not required to enter into a risk-based contract. You can choose whether or not you want to enter into a risk-based contract. But again, if you're a provider or an MCO at those high-level risks, they have to. They are required to work with CBOs. So that really puts a lot of the power in to your hands as sort of defining how you want to enter into this space. Okay, awesome. There's a question on the line. Would licensed housing be considered Tier 3? I have no good idea on that. I would love to be able to answer that. We can maybe talk offline and get you connected to somebody who is a better expert on housing licensure. My guess is that's going to be Tier 1, but it's probably all about how you bill for it. I apologize, I can be more specific, but I'll follow up with you offline. So, you're sitting back, you're listening to Andrew ramble on for a little bit here, and a question you might be asking is, great, what should I exactly be doing with all this information? And our advice is to look at the VBP roadmap document and look at some of the sections that talk about the different populations that the state is promoting for contracting. So there are a couple of examples they give, like there's a maternal health population, there is an integrated primary care population and contracting type or contracting category that the state is interested in seeing, and there's like two or three other types as well. What our advice is to do is to look at those populations and look at the VBP roadmap's description of those populations and see what connections you have to that space. So an example here is if you provide prenatal support services, the maternity bundle is the one for you. You can draw a really direct connection between the needs of that patient population and the services that you provide. All you have to do is prove that your services improve the health of that population, and you should be able to enter into some kind of discussion about becoming a part of that arrangement. There are some key limitations that we wanted to sort of just get out of the way about the VBP roadmap, having read through it. So first off, I would say go into reading it and have realistic expectations. It's a new thing for the state to be, and really the U.S. overall, to really be pushing forward with this much energy, and therefore it's not always as explicit as you would want. It's not a clear step-by-step blueprint. It really outlines, what the state's priorities are, what it wants you to think about, and sort of the questions that it wants you to be prepared to answer about your services and the value that it provides. It's not terribly specific on timeline. It provides sort of big milestones like we talked about earlier, and it sets some goals for how much Medicaid payments that the state wants to see tied to value-based payment programs and contracting by a given date. It doesn't really outline a whole lot of interim steps before those deadlines. And it also doesn't provide, help on how to enter into a negotiation with a provider or between providers and MCOs. There's a lot of offline work that you would have to do to, I think, make some of the information in the roadmap really actionable. So it sounds kind of defeatist, but really it's just the message here is go into it, as a document that can be really informative. We'll ask a lot of good questions to help you be really self-reflective about your services, but don't go into it looking for a manual on how to do VBP. Okay, so with that, let's pause again for questions. We're doing great on time. What questions do folks have about, what's in the roadmap? Any burning questions that you and your team have been thinking about for VBP? Any reflections on where your organization is at? Don't forget is that if you're speaking and no one's responding, you might be on mute because we had to mute everybody. So you should be able to press *6 or #6 to unmute yourself. Okie dokes. We will move forward. So with that, I'm going to go ahead and hand things over to my partner here, Rachel, who's going to walk through some of the resources that are available, that are freely available to you to continue your VBP learning.
Hi, everyone. And again, we encourage any sort of questions to come up. And if we can't answer them, we'll certainly make a note and look to make sure that we address them either offline or in future sessions if it's a meaty type of question. So thanks so much for joining us, and something that came out actually either early this week or last week from Greater New York Hospital Association was a guide that they've been working for months on after having several sessions with the workforce group of DSRIP workforce leads and different entities associated with that. They listened to what people wanted in a kind of more concise document and a little more substantial than as we laid out the VBP roadmap is. They really tried to make the content speak to what the PPSs were asking for in the way of guidance with VBP. So they just released that, and we actually are confirming whether or not we can share that openly with you all just as a single document. But I went through it and tried to find some of the most pertinent information for specifically that spoke to CBOs, and they had a lot of great information. So first, I wanted to highlight the SCAN Foundation Linkage Lab Initiative. So this actually was initially developed to prepare California's community-based organizations to partner with healthcare entities. So this is something that has been over multiple years they've been working on. But that effort also then partnered with the Health Foundation in Western and Central New York, who is doing some similar work. So they have a lot of great tools, and let me see if I can bring you all to this. Will this be showing beyond PowerPoint?
I think it's showing.
If anyone wants to go ahead and put it in the chat, if you can't see that I've transitioned to a web page. So this is the SCAN Foundation's website that was highlighted in the GNYHA document that I thought would be really helpful for CBOs. So it's got a lot of really great information. So some case studies and some past webinars about some of the work that they've done, but also a master table of contracts that CBOs have engaged with healthcare payers in. So you'll see this bullet here under results from the second cohort. So they've gone through a few different iterations of this effort, and you can kind of look to see what types of contracts have happened in the past and like the status of that and what those services were, what collaborations were happening around what services. And then additionally, some really great resources down more towards the bottom of the homepage, e-learning modules on building business acumen for CBOs, and then a CBO toolkit on pricing and sustainability as well. So these are just some pieces I wanted to bring your attention to quickly that we thought would be really helpful if you've gone through the state VBP university resources and haven't quite found things that resonate enough for the world of CBOs. And then we actually have a more substantial document as well that we have linked to in the PowerPoint, so we'll send out the slides with this. It's quite a lengthy document, but again, it goes through the process that Western New York, Central and Western New York has gone through, and this was before the world of DSRIP, as I understand it. So this was their effort to create community-based integrated care network. So similar, to when you think about the way that we talk about DSRIP, but this was, substantially engaging with CBOs, and there's a lot of lessons to be learned. So they outlined this in this document, and I think it's worth taking a look for you all. So that also was highlighted in the GNYHA document. And then a few sections within that that I thought were also really helpful. So the first is in the appendix, they have a condensed version of the social determinants of health intervention menu. So the DOH actually released this menu, and they have a much larger document to go through, and I won't get into it too much, but I think, again, like the good thing is about this is it helps CBOs to think about how to fit their services in the framework of health interventions. So how to fit your services into the context, and to think about the different elements that perhaps CBOs haven't had to think about before, haven't formalized, like the healthcare setting, such as different metrics and outcomes. So the third piece that I think will be really helpful is the framing of how CBOs add value. And of course, we can talk until, next year about all of the value that CBOs add, but what this appendix is specifically doing, and what I think it will be helpful for you all moving forward and thinking about VBP, is how to put it in the framework of the healthcare context. So I'm going to go ahead and borrow this image from that document, and it was actually developed from, I'm sorry, I don't have this is from the Greater New York document. There's an agency that actually created this, so I'm sorry, I'll have that in the notes just to make sure that we're attributing it. But the point of this is really to show kind of 4 major high-level categories of healthcare pieces that we want to look at. So when you're thinking about all of the amazing services that you provide and you know what the outcomes are, but what we really want to look to do is to think about where those services are fitting into and feeding into these high-level outcomes that healthcare setting is looking to impact. So preventing hospital readmissions, managing chronic conditions, activating beneficiaries. So where are you engaging members and helping them plug into the system like CMS? So really, we're thinking about how that you fit into specific healthcare contexts and outcomes, so the languages can merge and mix, and it won't be such a daunting thing to put your services in the context that we're trying to work within. So I'm hoping that this image is helpful and that it can help formulate how you can lay out your services when thinking about engaging with the healthcare sector. And we wanted to highlight some other resources. So of course the VBP roadmap document, it is very large and long, but really about a good 20, 25 pages are the majority of what you really want to focus on. Additionally, we have a navigation page we want to recommend, and that's actually from the hospital, sorry.
Yeah, I believe that one is United Hospital Fund.
Okay.
That one is really nice. Frankly, it does a much better job of explaining, again, this first 15, 20 page section of the VBP roadmap, I think, better than the VBP roadmap does. It's much more succinct. It's what I would go to if I were taking away some information from the VBP roadmap and bringing it to my team internally. Rather than sending my team this giant document to read, I think I would take excerpts from this resource number 2 and go from there.
And the third is also borrowed from the New York State resources, and they have these guidance images, kind of a one-pager for each provider type, so CBOs, BH, and primary care. And again, it's just a nice visual to help you walk through the steps that if you are, thinking about engaging in contracting, the things that you want to do, and to help you really conceptualize what it will mean functionally for your organization. So with that, I want to make sure that you have all the contact information, as always, for our partners at NYP Queens that have been hosting the VBP 101 sessions, Amanda and Sarah, and then Andrew and myself here. So basically, we are absolutely sponges and open for any feedback from you all about what will be most important to you moving forward in DY4 and 5. These sessions are really yours to meld, so we'll be taking all feedback, questions, and comments about future sessions, and who would be most useful to get in a room together, and to be speaking to you all about content that'll help your preparation in this. So happy to say that we have all of the past sessions, the streaming link for those recorded sessions, and then also all of the slide decks posted on the website. So this is the one that Andrew had mentioned earlier. And just so you know, our webinar page is broken down by topical section, so it's under population healthcare models. So It is early, but you know, any questions or any discussion that you all want to go ahead and bring up now, feel free, because the session is yours. We really just wanted to try to put the tools in your hands moving forward. We know that this is a really heavy topic and that people are not necessarily sure where to go to for more information. So yeah, feel free to bring up any topics that you want further discussed or any questions you have, please. All right, and to the previous question about the tier levels, I will be looking into this to see if there's any more guidance. I'd spoken with another CBO about this. I would say maybe it was last week that that they had also kind of tried to engage with the state to get more details on this, and as far as we know right now, there's not very much more detail. So you know, if there's nothing publicly available, I'll be looking to engage New York State to try to get more granular detail on some of these kind of nuances between the tiering, because I know it'll make a difference for you all engaging with healthcare entities. But other than that, thank you all so much for your time. Sorry this is a little bit short, but again, you know, we threw a lot of resources at you, and we're hoping to release more soon. So thank you all so much, and just feel free to follow up with us in the coming weeks via email, and we look forward to